Thanks for listening to this seminar. Before I start, I want to request every single one of you, if you like it, please subscribe and share with medical students and postgraduate students, practitioners, and other individuals who are interested in academic pursuits. Our aim is to bring in the up-to-date, accurate information to practitioners across the globe. With that introduction, we are going to talk about pediatric dermatologic emergencies part 1. The reason it is part 1 because there are a humpty number of diseases we have to talk about. Today we are going to talk about 10 of them. Bullous Impetigo, Staphylococcal scalded skin syndrome, Eczema Herpeticum, Eczema Coxsackium, Cutaneous Streptococcal infections, Ecthyma Gangrenosum, Angioinvasive fungal infections, Reactive infectious Mucocutaneous eruption, Drug-Induced Necrolysis, drug reaction with Eosinophilia, and systemic symptoms, otherwise called DRESS. Bullous Impetigo, the most common, almost everybody in pediatrics and in dermatology must have seen this one. It accounts for 30% of impetigo cases. It's caused by Staph aureus, especially the serine protease exfoliative toxins, which is secreted from Staph aureus, cleave desmoglein 1 in the superficial epidermis. It disrupts the cell-cell adhesion and causing the formation of bullae. The patients present with crusted circular plaques that may coalesce. In addition to the bullous impetigo, it can cause cellulitis, osteomyelitis, septic arthritis, pneumonia, glomerulonephritis, and sepsis. The lesions of the bullous impetigo will look like this. As you can see here, the bullae has burst open, leaving the raw surface behind it. And it can show the honey-colored crust with this pathognomonic of Staphylococcus aureus. In a neonate, again, the honey-colored crust again signifies infection with the Staph aureus. How do you treat? In the absence of systemic findings, or if the lesions involve less than 2% of the body surface, topical antibiotic like mupirocin, fusidic acid can help to resolve the impetigo. But in presence of systemic findings, or if the subcutaneous involvement is more than 2%, it's recommended to give systemic antibiotic therapy. That could be oral or intravenous. When you do intravenous, ampicillin or first-generation cephalosporins will suffice. Except in those communities with high risk of having MRSA, then one has to use antibiotics against MRSA such as vancomycin, teicoplanin, linezolid, or clindamycin. The skin cultures are rarely needed unless if MRSA is suspected. As I said before, if the involvement is less than 2% of the total body surface, use topical treatment such as mupirocin, fusidic acid. For children 2 months or older, one can use ozinosaxin if it is available. Systemic treatment is recommended when they have extensive lesions, meaning more than 2% of the body surface area. When there is resistant disease, that means not responding to the topical antimicrobials, or when there are systemic complications such as cellulitis, osteomyelitis, etc. Inpatient hospitalization and IV therapy can be considered for patients less than 1 year old and especially in neonates. The second disease we are going to discuss is Staphylococcal scalded skin syndrome. The Staphylococcal scalded skin syndrome is a blistering skin condition caused by exfoliative toxin producing strains of Staph aureus, similar to Bullous Impetigo. The desmogelin 1 is a target for the exfoliative toxins. It is present in superficial epidermis, but not in mucosal membranes. As a result, the Staphylococcal scalded skin syndrome do not affect mucosal membranes. This toxin spread via bloodstream. As a result, it can cause blistering and denuding of the skin across the body surface. It occurs frequently in children less than 5 years of age. When you are evaluating Staphylococcal scalded skin syndrome, look for the primary site of infection. The most common sites of localized primary infections are umbilical stump, diaper area, periorificial area like conjunctiva, nasal regions, and even sites like circumcision sites needs to be looked into and treated as such. These patients present with prodrome fever, irritability, and generalized fatigue. 24 to 48 hours later, well-demarcated tender erythematous patches appears, usually starting on the face or flexural areas such as neck, axilla, and groin. Then they coalesce into diffuse, confluent erythematous rash. After several hours after that presentation, the fragile blisters develop that progress to flaccid bullae, which rupture and lead to large sheets of epidermal exfoliation. As you can see here, the bullae burst and expose the ARI area, and also you can see the exfoliation in the perioral area and also around it. This is another picture showing erythroderma patches, and I think it is going to form bullae and blisters. Within 23 hours of desquamation, the denuded areas develop a thin, shiny, dry crust with periorificial fissuring. Staphylococcal scalded skin syndrome is a clinical diagnosis. Cultures are useful if they are positive. How do you treat? Use antibiotic therapy, typically nafcillin, oxacillin, or first-generation cephalosporins. In high prevalent MRSA areas, one should consider MRSA antibiotics such as vancomycin, linezolid, etc. Managing the fluid losses is very important part of treating Staphylococcal scalded skin syndrome. There are other mimickers similar to Staphylococcal scalded skin syndrome that need to be considered during the diagnosis and treatment. The first being drug hypersensitivity reaction. In this one, it's very easy. There is a history of exposure to a drug, prior drug sensitization. Then they develop exanthematous eruption, macules or papules up to 1 centimeter in size, which may progress to becoming confluent. Usually, they are pruritic. They have symmetric distribution on trunk and extremities, may be limited to face and extremities in children. Systemic involvement is low in patients with drug hypersensitivity. Second most common is systemic viral exanthem. They often have a prodrome of fever, malaise, coryza, sore throat, cough, rhinorrhea, nausea, vomiting, diarrhea. Then they develop maculopapular rash, initially discrete, pink, often become confluent. Develops typically centrally on the head, neck, trunk, and proximal extremities. It's usually self-limiting. Third is Bullous Impetigo, we already discussed. Usually localized skin lesions, erythema, blisters, and exfoliations you can see. In children, you should consider scalp burns. In those patients, you should have a clinical suspicion of child maltreatment if it is intentional. History of injury, development level of child, presence of risk factors presence of other unexplained injuries can raise the red flag. Irregular shapes and configuration, partial thickness, localized superficial red blistered, full thickness white charred translucent, pinprick in the burn area. But sometimes it can be accidental too, so one should keep in mind. Other two diagnoses you should consider is Stevens-Johnson's and toxic epidermal necrolysis. Usually it's associated with the history of drug intake. In fact, 80% of the patients have associated drug intake. It could be idiopathic too. It's most commonly seen in adults older than 40 years. However, it can occur at any age. They can experience prodrome, fever, malaise, arthralgia, and skin tenderness and pain. The Stevens-Johnson's typically affects less than 10% of the body surface. TEN, toxic epidermal necrolysis, often involves more than 30% of the body surface area. Initially confluent erythematous pruritic macular rash that progresses into bullae and epidermal detachment on face, trunk, and extremities. Palms and soles are involved. Sheet-like loss of full thickness epidermis, Nichols sign is positive in these two conditions. Painful oral lesions on lips and buccal mucosa one can see. Conjunctival ingestion and lesions on corneal erosions. In contrast to Staphylococcal scalded skin syndrome, it does not involve the mucosa because the toxin does not, it is targeted against only the desmoglein 1, which is not present in the mucosa. Another disease one should keep in mind is Kawasaki syndrome. The typical Kawasaki syndrome, you will have prolonged fevers anywhere between 3 to 10 days, constitutional symptoms, diarrhea, arthritis, and photophobia, along with 4 of the 5 clinical signs required for this diagnosis. Cervical lymphadenopathy, bilateral conjunctival injection, usually bulbar, and lips are dry, red, and cracked. Diffuse erythema of the oral mucosa, strawberry tongue, edema and pain to extremities, diffuse scleratiform or deeply erythematous maculopapular rash, beginning with erythema to palms and soles, spreading to generalized exfoliation of trunk and extremities with subsequent desquamation. The third condition we are going to talk about is Eczema Herpeticum. It is one of the complications of atopic dermatitis, as you all know. It is a chronic inflammatory skin condition. Intensely pruritic eczematous eruptions happen mostly in flexural areas and affecting 1 in 5 children. These children prone to bacterial and viral infections due to skin barrier defects, altered cutaneous immune activity, alteration of cutaneous microbiome. Eczema herpeticum, as the name says or name indicates, caused by herpes simplex virus. It is a superinfection of atopic dermatitis. Not everyone develops eczema herpeticum, but there are some risk factors, especially those who have severe or early onset atopic dermatitis. High serum IgE, high peripheral eosinophils, and associated other comorbid allergic diseases. Presence of or history of cutaneous Staph aureus infection predisposes to get HSV infection more than those who do not have. The alpha-toxin released by Staph aureus increases the likelihood of HSV replication by allowing entry of HSV into keratinocytes. It presents with disseminated monomorphous vesicles or ulcers on an erythematous background. It preferentially involves head, neck, and trunk. Often associated with other symptoms like fever, lice, lymphadenopathy. Sometimes it's complicated with keratoconjunctivitis, herpes encephalitis, or otitis. As you can see in this picture, you can see the involvement of face, neck, the upper trunk. The lesions are monomorphous on erythematous background. It is a typical of Eczema Herpeticum. Diagnosis is often made on clinical morphology alone. Sometimes one need to do a PCR to make sure it is Eczema Herpeticum, because there are other mimicking conditions like Eczema Coxsackium and bacterial superinfection that can happen in atopic dermatitis. Serologic studies are not recommended. Prior to the development of effective antiviral treatment, the Eczema herpeticum was associated with high mortality to the range of 10 to 75%. With the advent of oral and IV antivirals such as acyclovir and valacyclovir, the mortality is much diminished, almost to nil. One should also treat underlying bacterial infections when you are addressing Eczema herpeticum. Sometimes Eczema herpeticum is recurrent. In those patients, antiviral prophylaxis or using tupilumab, it is a monoclonal antibody against IL-4 and IL-3, can prevent the recurrent Eczema herpeticum. The next one is Eczema Coxsackium. Again, it is a complication of atopic dermatitis. It is caused by Coxsackie viruses, most commonly by Coxsackie virus A6. It presents with widespread vesiculopapular eruption with erosions in areas of atopic dermatitis. It is a delayed cutaneous manifestation such as acrodesquamation and onychomatosis can happen. Eczema Coxsackium involves face, palmoplantar skin, and also buttocks. As you can see in this picture, it is less severe than Eczema herpeticum, and it involves predominantly trunk, buttocks, and areas. Sometimes it's difficult to distinguish between herpeticum and Coxsackium, so doing a PCR test, if it is available, can distinguish so that you do not have to prescribe antiviral agents. If it is clinically unclear, PCR for HSV is recommended. Eczema Coxsackium is self-limited. Treatment is same as for atopic dermatitis, including emollients and topical corticosteroids. The next subject is cutaneous streptococcal infections. It's caused by group A streptococcus, otherwise called Streptococcus pyogenes. It can cause scarlet fever, streptococcal toxic shock syndrome, and necrotizing fasciitis. We will talk necrotizing fasciitis in part 2. This particular one, we will confine ourselves to scarlet fever and streptococcal toxic shock syndrome. Scarlet fever. It's caused by an exotoxin producing Streptococcus pyogenes. This are all, as you know, is a gram-positive beta hemolytic cocci. It affects all age groups, but most commonly occurs between the ages of 5 and 15. Sudden onset of fever and malaise 2 to 3 days after infection occurs. Patient may have pharyngitis or tonsillitis. Characteristic dermatitis of scarlet fever is typically seen 2 days after onset of infection. Blanching erythematous dermatitis, which starts on the trunk and spreads outward. It spreads the face, palms, and soles. Other cutaneous findings include facial lines, meaning there is a linear accentuations of dermatitis in flexure areas. As you can see, there is a sparing of hands, and it start as discrete, then it will become confluent and presents in trunk and extremities. The complications of scarlet fever, as you all know, acute rheumatic fever and post-streptococcal glomerulonephritis. So the prompt antibiotic treatment is necessary, especially with penicillin or amoxicillin. If the patient is allergic to penicillin, one should use cephalosporin, azithromycin, clarithromycin, or clindamycin. The gold standard for testing scarlet fever is throat culture, but it does take time. Now the rapid antigen detection tests are available everywhere in the globe, so that can be used to make the diagnosis promptly. Streptococcal toxic syndrome, and again, one should distinguish Staphylococcal toxic shock syndrome and Streptococcal toxic shock syndrome. Since we are going to talk about Streptococcal toxic shock, let's review Staphylococcal first, subsequently Streptococcal TSS. The Staphylococcal TSS usually have fever more than 38.9 centigrade. They have diffuse macular erythroderma. Desquamation happens 1 to 2 weeks after the onset of illness, particularly on palms and soles. Hypotension, systolic blood pressure is less than 90 in adults, less than 5th percentile for children less than 16 years. They often have multi-system involvement. They should have at least 3 of the following. Gastrointestinal, they can present like vomiting or diarrhea. Muscular, severe myalgia or elevated creatine phosphokinase, twice the upper limit of normal. Mucous membrane, like hyperemia of any mucosal surface. Renal, BN creatinine, twice the upper limit of normal. Hepatic, bilirubin, twice the upper limit of normal. Hematological, platelets less than 100,000. In central nervous system, disorientation, combativeness, or alterations in consciousness without focal neurological signs. The Streptococcal TSS, similar but little different. They need to have hypotension, the same parameters apply. 2 or more of the following signs of renal impairment, coagulopathy, hepatic involvement, ARDS, meaning acute respiratory distress syndrome, generalized erythematous macular rash that may desquamate, and soft tissue necrosis, including necrotizing or myositis or gangrene. Little different, more or less very similar. So they mimic each other. How do you differentiate? But isolating streptococci from either sterile sites such as blood, CSF, joint, pericardial, pleural, peritoneal fluid, and tissue biopsy. Sometimes you need to isolate beta-hemolytic streptococci from non-sterile sites such as throat, vagina, and sputum. And negative results for Staph aureus. How do you treat? Staphylococcal toxic shock syndrome, again grouped into 2, menstruating, associated with the menstruating females, and a non-menstruating toxic shock syndrome. So how do you treat? Let's talk about Staphylococcal toxic shock syndrome. It's again 2 groups, menstruating females with toxic shock syndrome and a non-menstruating person with toxic shock syndrome. Treatment is based on whether you have high risk factor for MRSA or you have no risk factor for MRSA. If there is no risk factor for MRSA, oxacillin, nafcillin, or cefazolin suffice. When there is high risk for MRSA, one should consider vancomycin or daptomycin or linezolid or clindamycin. The streptococcal toxic shock syndrome, again grouped into 2, whether associated with necrotizing soft tissue infection or not associated with necrotizing soft tissue infection. When it's not associated with necrotizing soft tissue infection, one can treat with penicillin, ampicillin, and amoxicillin. If there is an associated with necrotizing soft tissue infection, one should add metronidazole along with piptazo or cefotaxime 3rd generation cephalosporin, or metronidazole with ceftriaxone or piptazo. If there is an associated MRSA risk factors, again daptomycin, vancomycin, or linezolid needs to be added. In addition to these antibiotics, we often use antitoxic agents, primarily clindamycin or linezolid. These antibiotics not only acts on the bacteria, it also blocks the toxin released by staph and strep. Next is Ecthyma Gangrenosum. It's a cutaneous infection most often seen in an immunocompromised host. It's caused by Pseudomonas aeruginosa in majority of the patients, like 50 to 74% of the patients, they have Pseudomonas aeruginosa infection. The most common underlying condition is acute lymphoblastic leukemia. The mortality rate is very high, 20 to 77%. In the absence of sepsis, the mortality rate is only 15%. Still, it's very high. The risk factors are neutropenia, septic shock, multi-drug resistant infection, and delayed antibiotic therapy. So the recognition has to be prompt and start anti-pseudomonal along with appropriate antibiotics as soon as possible. The clinical presentations is a painless erythematous or violaceous macules or papules which rapidly progress to hemorrhagic bullae. Then penetrating necrotic ulcers with black fissures within 12 to 24 hours. Lesions may be single or multiple. It commonly involves perineum, lumbar, and gluteal regions in most of the patients. It's very imperative. Doing a good examination is mandatory to identify this Ecthyma Gangrenosum. In 30% extremities, 6% face, and neck and torso involves 6% of the patients. The lesions look this bad when you see any similar lesions or even milder variety, broaden the antibiotic, include anti-pseudomonal therapy, and involve pediatric surgeons immediately. Empirical therapy must include agents with anti-pseudomonal. Once cultures have resulted, the treatment can be narrowed. Surgical debridement of necrotic areas must, along with antibiotic and other supportive treatment. If the skin denudation or skin involvement is extensive, skin transplantation may be necessary. Next one is angioinvasive fungal infection. These are all uncommon, fortunately, but seen in immunocompromised hosts. It can result in high morbidity and mortality. It's caused by Candida, Aspergillus, and mucormycosis. The risk factors for these fungal infections are myeloblastic leukemia, recurrent acute leukemia, high-risk ALL, and recipient of allogenic hematopoietic stem cell transplantation. It usually originates in the lungs with the hematogenous spread. Primary cutaneous infections are associated with nosocomial infection. It's often seen at sites of skin trauma such as adhesive tape dressing or catheter incision points. Again, these patients are immunocompromised host with neutropenic fever. The typical presentation is pink, necrotic, or hemorrhagic, or eroded papules or nodules. It should be immediately evaluated with low threshold for skin biopsy for culture and histology, and immediately broaden the antifungal therapy. Local debridement for source control and systemic evaluation for other sites of infection, such as eye, heart, and kidneys needs to be evaluated right away. The lesions will look like that. When you see in neutropenic or any other immunocompromised host, immediately do culture, biopsy, and broaden the antibiotic therapy and antifungal therapy. Next is reactive infectious mucocutaneous eruption, otherwise called RIME. It's a post-infectious dermatologic reaction. Initially, it was known as MUM, meaning mycoplasma induced rash and mucositis. Now it is no longer called MUM, it is instead called RIME, because it can be caused not only by mycoplasma, even though it is the most common infection, but it can be caused by COVID, chlamydia, and influenza. In many cases, pathogen cannot be identified. The RIME should be considered in the following situations: when there is no medication history and mucositis involving 2+ areas, minimal to severe skin involvement, and characteristic sparse vesiculobullous targetoid eruption. I'm going to show you these pictures. As you can see, 1 mucosal involvement, 2 mucosal involvement, skin involvement, and the targetoid lesions. The 96% of RIME involve oral lesions, 76% ocular, 52% genital, and half of them will have cutaneous involvement. RIME does not have that much of mortality, but it has a high morbidity with a prolonged hospital course because they cannot eat because of severe mucositis involving 96% of the patients. The pain control is another issue. They may need pain control and feeding issues. And ocular sequelae needs to be addressed in concert with ophthalmologists. As I said earlier, most patients make full recovery and the mortality rate is low. The recurrence occurs in 8 to 38% of the patients. RIME can be distinguished from DEN, which is drug-induced necrolysis, by lack of medication history of either you being started earlier or soon after the prodromal symptoms. The treatment is primarily supportive care and giving pain medication. Often we need to use ophthalmology, oral medicine, and urology consults. Usage of antibiotic immunosuppressive treatments such as systemic corticosteroids, cyclosporin, etanercept, or IV immunoglobulin can be considered in the treatment. Severe cutaneous adverse reactions, otherwise called SCARs. It's uncommon, often associated with pharmacological agents such as lamotrigine, acetaminophen, and allopurinol. There are 3 kinds: DEN, DRESS, and AJEP. Drug-induced necrolysis, drug reaction with eosinophilia and systemic symptoms. AJEP we will discuss in the next session, part 2, acute generalized exanthematous pustulosis. Drug-induced necrolysis, spectrum of cutaneous delay type drug hypersensitivity reaction that includes 2, Stevens-Johnson and toxic epidermal necrolysis. It can be as severe as what you are seeing in this picture. 80 to 95% of cases of Stevens-Johnson's in turn are attributable to medications. Pediatric patients, infectious causes are more usually viral causes. DEN, drug-induced necrolysis, have a relatively high mortality, 4 to 16%. Greater the surface area involvement, higher the mortality. Treatment, there is no consensus at this point. Immunomodulatory therapies, systemic corticosteroids, cyclosporin, IVIG, TNF agents such as etanercept can be used. Mostly, it is supportive therapy similar to burn care, often improves these patients. Drug reaction with eosinophilia and systemic symptoms such called DRESS. DRESS is a severe type of type 4B delayed hypersensitivity reaction. The mortality rate is 2 to 10%. DRESS occurs 2 to 6 weeks after the initiation of the offending drug. With the re-exposure, it can happen fast. The DRESS syndrome presents with prodrome of malaise, pruritus, before development of skin changes and fever. The rash starts as a pruriginous marbiliform eruption on the face, upper trunk, which progresses rapidly to involve over more than 50% of the total body surface area. Facial edema is common. Rash may progress to erythroderma in 20 to 30% of the patients. As you can see here, start with the discrete, then become confluent, then erythrodermic. This child has a facial edema, which is characteristic of DRESS. It's often associated with lots of drugs, anticonvulsants, antibacterial, antituberculosis, antiretroviral, hepatitis C, pyretic, analgesic, sulfonamides, targeted therapeutic agents, and other medications. So one should evaluate exposure to all these medications. And also there are certain medications have been associated with certain HLA alleles. That means there are certain patients who are predisposed to develop DRESS syndrome when they exposed to this particular medication like allopurinol, carbamazepine, dapsone, nevirapine, and phenytoin. The clinical symptoms happens like this. There is latency of 3 to 8 weeks. The antibiotic or the medication was taken 3 to 8 weeks before. Then you develop first fever followed by skin rash. As you can see, fever appears and disappears. The rash appears and present over many weeks. And it can associate with other internal organ damage, and hematological abnormalities will become prominent in that order. Then it can persist, but gets better as the day progresses. On exam, they will have a fever of 38, enlarged lymph node 38 and above, enlarged lymph nodes, and eosinophilia. That is a distinguishing feature of this syndrome versus other rashes, which we discussed. Atypical lymphocytosis, skin rash oftentimes affects more than 50% of the body surface area. Skin biopsy suggests DRESS syndrome and other organ involvement. You will see that one. And rash resolution takes more than 2 weeks. And make sure these patients do not have other diseases like hepatitis viruses, mycoplasma, chlamydia, and antinuclear antibody, and draw blood culture, make sure there is no other bacterial agents involved in it. And one can use the Regis Care scoring system for diagnosing DRESS syndrome. The treatment is discontinue the causative medications. Start corticosteroid therapy, early initiation of systemic steroids, and gradual tapering over 3 to 6 months. The dose usually starts with 0.5 to 1 gram per kilo, and they taper it over 3 to 6 months. Mild cases one can treat with topical corticosteroid, but most of the patients will end up needing systemic corticosteroid therapy. If the DRESS syndrome associated with anticonvulsants, treatment with N-acetylcysteine may help. The most common cause of death in DRESS is because of hepatic necrosis. So one should monitor renal function test, liver function test, and coagulation factors, NCBC. The negative prognostic indicators are coagulopathy, thrombocytopenia, pancytopenia, leukocytosis, and other comorbid conditions like chronic kidney disease, allopurinol, and exposure to minocycline. Recovery from DRESS syndrome lasts an average of 6 to 9 weeks. So follow-up is necessary for these patients. 20% of the patients, that means 1/5 of the patients, can have relapses. And also one should monitor for long-term complications such as hypothyroidism that can occur months or 4 years following the resolution of acute reactions. Number one, making the diagnosis right, treating with systemic corticosteroids, and monitoring for other internal organ damages like kidney, liver, and the coagulation panel, and follow up these patients for developing hypothyroidism for all the way to 4 or 5 years after the resolution of acute reaction. This concludes Pediatric Dermatology series number 1. The next week we will see number 2. As I requested before, if you like it, please subscribe and share it with medical students, practitioners, postgraduate students, and other people who are interested in pursuing academic careers. And I really appreciate listening to this topic and spreading this one to everyone you come across. Thank you so much. Appreciate it.